She's in your office crying. She doesn't know why. She's exhausted. She's snapping at her kids. She can't concentrate. And she feels like she's losing her mind. And she has never felt this way before in her life. You start building a case for depression, maybe anxiety or burnout. But what if none of those are right? What if what is sitting across from you is not a mental health crisis at all, but a hormonal one? Today, we're talking about perimenopause and why missing it is one of the most common clinical mistakes happening in the therapy offices right now. If you work with women between the ages of 35 and 55, and most of us do, this video is required watching because perimenopause does not announce itself. It doesn't come in with a checklist. It just walks right into your office looking exactly like depression, anxiety, ADHD, and burnout. And if you don't know what to look for, you will be treating the wrong thing for years. So let's change that. Perimenopause is the transition period before menopause. It is not menopause itself. That's when periods have stopped for 12 consecutive months. Perimenopause is everything leading up to that, and it can last from 2 to 10 years. It typically begins in the mid-40s, but I've seen it as early as 35. The hormonal shifts during this time, primarily estrogen and progesterone, are erratic, not a steady decline, erratic, up and down and unpredictable. And that instability is exactly what drives the mental health symptoms. Here's what most clinicians don't know. Estrogen is not only a reproductive hormone, it directly regulates serotonin, dopamine, and norepinephrine, the neurotransmitters we associate with mood, motivation, focus, and emotion regulation. When estrogen fluctuates, so does everything else. Here's what perimenopause looks like in your therapy office, and I want you to notice how closely this mirrors other diagnoses. Mood symptoms, depression that comes out of nowhere, crying without knowing why, rage that feels disproportionate and confusing, emotional swings that do not match life circumstances, loss of motivation and interest in things that she used to enjoy. Anxiety symptoms include panic attacks with no clear trigger, racing thoughts, especially at night, a sense of dread or doom that she can't explain, hypervigilance and irritability. Cognitive symptoms look like difficulty finding words, knowing the word but can't access it, brain fog, difficulty concentrating, memory lapse that feel alarming, difficult decisions making. Physical symptoms showing up in session look like fatigue that's not improved with rest, sleep disruption, difficulty falling, staying asleep, waking too early, hot flashes, night sweats, joint pain, and headaches. Now, here's the clinical problem. Most of these women have not had mental health history. They are in their 40s, things are going well on paper, and suddenly they feel completely unlike themselves. They come to therapy because they do not know what else to do. And we, doing exactly what we're trained to do, are treating symptoms for depression and anxiety. And sometimes that helps a little, but it does not get to the root cause because the root is hormonal. The research that is clear and has been clear for years, but is not made into most clinical training programs. A review published in the Journal of Menopause found that perimenopausal women have 2 to 4 times higher risk of developing depression symptoms than perimenopausal women, even when they have no prior history of depression. 2 to 4 times higher. That is not a small finding. In a JAMA Psychiatry article, found that the risk for first-time lifetime depression episode is significantly elevated during the perimenopausal transition, meaning women who have never been depressed before are becoming depressed for the first time because of hormonal changes. And research on cognitive symptoms found that the word finding difficulty and memory lapse women experience during perimenopause are real, measurable, and tied directly to the estrogen fluctuation. Not dementia, not ADHD, not anxiety. Hormones. These women are not imagining it. Their brains are changing, and we need to be the clinician who knows that, who looks for that. Here is where it gets frustrating. The average woman in perimenopause sees 3 or more providers before someone connects her symptoms to hormones. She goes to her primary care doctor. She gets told her labs are normal, and that is often true because standard hormone panels are a snapshot in time, and Perimenopausal hormones levels fluctuate so dramatically that a single FSH level tells you almost nothing. She gets referred to therapy. We treat her depression or anxiety. Sometimes medication is added, and she keeps coming back because she is not getting any better, because no one asked her the right questions. The right question is, where are you in your cycle? Is your cycle changing? Are you experimenting any perimenopausal symptoms? Those three questions can redirect years of misguided treatment. You do not have to be an endocrinologist. You do not have to manage her hormones. You just have to catch it and refer her. Ask every woman between 35 and 55 presenting with new onset mood symptoms, anxiety, cognitive complaints, or sleep disruption. Has your cycle changed recently? Length, flow, regularity? Are you experiencing hot flashes or night sweats? Have you noticed changes in your sleep that feels different from before? Has anyone talked to you about perimenopause? Document what she tells you, include it in your clinical picture, then refer her to a provider, not just a gynecologist. Ask specifically for someone who has experience with hormonal health and perimenopause. Integrative medicine providers, OBGYNs who specialize in menopause, and certified menopause practitioners are your best referrals. The Menopause Society website has a provider finder on their website. That is a resource worth bookmarking. While she is getting that evaluation, continue therapy. Address the emotional experience of feeling like a stranger in your body. Normalize what is happening. Psychoeducation can alone be enormously relieving for those clients, and coordinate with her medical provider when possible. You're not diagnosing or treating the hormonal piece, but you are part of the clinical team. Perimenopause is not rare. It is not a niche clinical topic. Every woman is going to go through this, and most of them will spend time in a therapist's office during the transition, confused, frightened, and looking for answers. We have the opportunity to be the first person who actually connects the dots for her. That is not outside our scope. Recognizing that something medical may be driving the presentation and making the referral is exactly within our scope of practice. Ask the question, make the referral, change the trajectory. If you want more clinical education on the intersection between mood and mental health, continue to follow this channel. This is where I talk about that specifically. I also provide CEU trainings with topics similar to this that are designed specifically for clinicians who want more at this medical versus mental health intersection. Follow me and subscribe below.